City, Missouri today. Unlike most days in January, we're going to be about 60 degrees, so we're all smiling here in the Midwest. We do appreciate the chance to work with InTouch and do this presentation today. And as you can probably tell, the title has been modified just slightly. We've tried to capture some of the essence of Kansas, and there's no place like home for healthcare. And thinking about how most of the patients that we serve here in the Midwest, we are a bi-state facility. We sit right on the line between Kansas and Missouri. And because of that, we treat a wide variety of folks in this region. A lot of them reside in rural communities or counties. In fact, we discovered that 20% of the counties in Kansas and Missouri don't have ready access to specialty care. So what we've endeavored to do, what you'll hear from both myself and also my cohort in crime, Dr. Gary Ripple, is just a little bit of how St. Luke's has tried to address that issue and the shortfall that comes in healthcare when you look outside the metro areas. First thing I'd like to do is maybe give you just a slight background on how we came to be where we are now. We have a program that is very robust, and I can say that as a facility and as a healthcare provider and as a system, we were very early adopters in the whole field of eHealth, telemedicine, and telehealth. And we always ask ourselves, are we ahead of, are we in, or are we behind the eHealth wave? Because most of you who have taken time today to listen to this webinar, you're probably somewhere in or ahead of the wave because you want to stay in that mode and you want to stay aggressive in your field. What we looked at from 1998 when we did our first telemedicine program in Anderson County, Kansas, which is in Garnett, we did a dementia screening. It was part of a grant program, and when the private grant dried up, obviously the program went away. But it put us on a pathway that led us into the early 2000s when we started an e-cardiology program, and then on to 2006 with ePsych, and then also 2007 where we initiated our electronic ICU. And we were the fifth one in the United States to adopt this type of technology. And again, I think it makes a very strong statement that St. Luke's is a very early adopter of this type of technology and how it leverages the ability to transfer knowledge quickly. Moving forward, in 2010, there was a kind of a watershed moment for St. Luke's when we realized that we've been doing all of these silo type events until 2010 when we actually designated a cost center for St. Luke's eHealth. And at the moment that we designated the cost center, that puts you into a budgetary mode. It gives you presence at the executive table when people are talking about planning and moving forward. And as we developed that cost center, we also established what we call an e-governance team. And I can't stress how important that step was within St. Luke's in the development of eHealth, because that allowed those from the C-suite, our executive suite at St. Luke's, program directors, product line managers, IT, legal, marketing, all of those players came together and recognized and really, if you will, validated the idea of telehealth and telemedicine in our health system. And we see that because of some of those early steps that we took in our development has really put us on a strong path to be viable long term. Just a couple of quick quotes. I know that when we look at different programs that develop, you usually define or develop an elevator speech. And what we tried to do is to realize that through telemedicine and eHealth, we're really able to change the way that healthcare is delivered, not only in our system, but in other systems that are in about 150 or 200 mile radius around St. Luke's, just simply by being very comfortable with the idea of this technology being implemented. One of our favorite quotes is, in a time of drastic change, it's the learners who inherit the future. The learners usually find themselves equipped to live in a world that no longer exists. And that's where I believe healthcare is right now, because the world in which most physicians and providers have practiced up until now, it's not going to exist in a few years. Whether it's a change in reimbursement models, or whether it's a change in practice styles, or the advancement in different quality aspects of healthcare, some of those old ways of practicing and providing care are going to be reduced as new and faster, if you will, ways of connecting take their place. In our day and time, you hear often the phrase situational awareness. And we look at that from a perspective of eHealth being in the midst of a very rapid change in healthcare. And we want to be situationally aware of where those opportunities emerge. Oftentimes, if we set our strategic plan and we get into a mode of hitting those targets and hitting those objectives and those goals, we sometimes miss opportunities if we're not situationally aware where those pop up. If you look on the left of the graph over here where it talks about traditional access points, we talk about a primary care office and how at a low acuity level, patients access that primary care office for care. And then if you go all the way over to the right, they usually use in a high acuity situation an emergency department. And what we want to try to do through telemedicine and eHealth is to actually facilitate a consumer-oriented service delivery site that fills the gap. We don't want all things to go to the emergency department. Obviously, we've been in that mode for some time in healthcare, and we know that it's a high cost and a high volume situation, our EDs, that slows down the level of care. What we want to do is be able to create virtual visits, use online retail clinics and pharmacies, and then also compile or compress that with our urgent care centers so that people from all over this region would be able to have ready access either through their handheld or their computer, through retail clinics and also the urgent care. Some of the driving provider questions: should we partner to establish retail clinics? Should we build or expand urgent care footprint? Is virtual care something that we should provide? And everyone on this phone should be asking those types of questions. And I think if you've got a very proactive medical staff and those that are forward thinking, they're going to be answering those affirmative with each one, including the virtual partnerships and virtual care. One of the reasons that we see there's a high need or a serious need to be situationally aware is that consumer interest is evolving. When you look at this study that was done of 519 participants, they asked them the questions about would they be interested, extremely interested, moderately interested in using telemedicine for minor ailments. And as you can see out of that, the study that was done by healthcare IT leaders, that upwards of 72% of those people said, yeah, they would be either moderately or extremely interested, very interested in using eHealth or telemedicine as the venue for that care for minor ailments. Certainly not a venue for anything serious or high acuity, but we really believe that this speaks volumes about how we can be situationally aware and start addressing consumers where they live, both physically and also virtually in their minds. A big piece of how we've grown our eHealth program at St. Luke's is looking at reimbursement models. I know when we first started back in 1998, everyone said, oh, it'll never fly because there's no reimbursement for this. And they were right as rain, simply stating that if we don't have a margin, there is no mission. So we looked at it from a standpoint of how do we develop those margins? How do we develop models that actually bring reimbursement to St. Luke's Health System? We, fortunately or unfortunately, are still in a very strong fee-for-service and venturing into a value-based model here in the Midwest. If those of you are listening from the East or West Coast, you're more into the population health management and more into the patient-centered medical home and more risk-based models. We've not gotten there yet, but we know that it's coming. Regardless of what happens in healthcare, we know that those models are going to continue to evolve, and wherein we will be more responsible and take on a higher risk in keeping patients healthy and well and managing them at a low cost point. As we do that, we see telehealth, technology, telemedicine, eHealth, all of those elements of it, from ambulatory wellness programs to post-acute and everything in between. We see telemedicine as being able to help reduce cost and manage chronic disease in areas that we haven't touched to date. As I mentioned, the e-governance committee that was established, they were very forthright in establishing goals for the eHealth department. So as Dr. Ripple and I partnered and we looked at it from 2010 forward, we had a set of 4 specific goals that we were to accomplish. We revised those, and these are our current goals for 2015 moving forward, and that is clinical integration, asset management, scale, and cost. And we feel that each element that we bring to the table to the executives on our e-governance team, we have to make sure that we've vetted it through each one of these 4 models, so that whether we're expanding a new cardiology clinic in an outlying area or developing a new e-pharmacy site, we have to see, is that contribute to asset management? Is it scale? Is it cost? Is it working toward clinical integration? And as you can see from our Vision 2020 model, we have certain objectives and key integration strategies that we are looking at with our eHealth program to make sure that we're consistent with the system overall strategic plan. And I would encourage, again, all of you that are either, depending on what stage you are in the development of your telehealth program, sit down and spend some real specific time with your system's strategic plan. And as you develop ideas or thoughts around that program, make sure that you're plugging in key phrases, key points along that strategic plan to help validate why you're doing what you're doing. Everyone likes to be in the sweet spot, whether it's on the baseball field hitting the ball or whether you're out there and trying to develop new programs. We tried to identify that through some of our data management here at St. Luke's and also some consulting arrangements that we've exercised, and that being, where is the opportunity for growth for our telemedicine program? When we look at regional relationships and their clear impact on patient behavior and metro inpatient market share, we looked at about 100 and 120 miles around, 150 miles around Kansas City. And as we did, we began to see that there's a big opportunity because only 3% of our patients or inpatients came from 100 miles or more away. Well, very few times can you sit in a cardiologist or a neurologist's office and they're saying, sure, I'd love to drive 100 miles one way to see patients. Our ability to transfer their knowledge to that outlying area is resident within eHealth. So as we look at that sweet spot, if you will, around Kansas City, there's very limited competition for those patient lives out there at this time. So we said if we can transfer the knowledge of St. Luke's and the expert care that we have here in the metro area out to those outlying areas, we can begin to build those regional relationships that will clearly impact our inpatient market share here in the city. One of the models that Dr. Ripple developed for us early on was how eHealth touches the lives of patients from pre-birth to death. And if you look at this graph just for a moment, we'll start at the top. Everything in blue are things that we're actually doing right now at St. Luke's. Now, I can tell you that we started working together in 2010. A lot of this was black, meaning that we hadn't started. It was a great idea, but we hadn't really engaged and started offering those services just yet. So as of today, we're offering those things in the area of outpatient services that would be considered wellness or patient education type programs, all the way through the continuum to home monitoring, home consultation, and then the physician virtual home visits. We're not there yet, but we're very close to pulling the plug on providing some of those type services. Our specialty telemedicine clinics are kind of where we cut our teeth, and that being obviously with psychiatry, which I'm sure a lot of you in your programs are providing telepsych, but neuro, endocrine, wound, allergy, pulmonary, nephrology, liver disease management, nephrology, oncology, all of those things that allow us to project our specialty care to these outlying areas, both on an outpatient setting for regular outpatient clinics, but even more so since 2011 and the CMS pivot toward reimbursement for inpatient telemedicine consults, we're doing more inpatient in each one of these. As you see, e-pharmacy, e-hospitalist, e-consulting in each one of these elements. We're planning all of these as far as inpatient consults in the future with endocrine, neurology, emergency services through our ED, palliative care, which is a wide open field right now in the field of telemedicine, wound care, rheumatology, and others. EICU, as you saw in 2007, St. Luke's was an early adopter. We service not only St. Luke's hospitals, but we also service hospitals that are dispersed through Iowa, Kansas, and Missouri. And we also have our eNICU program. This is just a graph to kind of give you an idea of the breadth of what we do in telemedicine. There are about 74 hospitals in this region that we call our sweet spot. We don't service facilities in each one of those hospitals, but we do look at about 66 counties where we actually have the opportunity to impact care from an outpatient, inpatient, or an ancillary service type program, whether it's through our e-pharmacy or others. So really understand and define that market and know who those players are so that you can understand where your sweet spot or where your opportunity is for your facility. I'm sure from your data management department you can find out where your referrals are coming from. And we look at it from a zip code standpoint. And as we identify those zip code locations where we're getting patients, we think, okay, can we work with either the pre-hospital or the post-acute setting to help understand what we can do better to keep those patients either out of a hospital situation or keep them at home versus sending them to a metro. And that's one of the buzzwords. I know our original title of keeping butts in beds, it was just a little bit provocative, so we decided to change it. But in doing so, it really speaks volumes to what local administrators, in fact, one of the local facilities we work with is where the phrase was coined, being able to keep those patients, appropriate patients, locally, and only transfer those that need a higher level or a higher acuity care. This graph gives you just a small idea about how we are addressing care in the outlying area. As you'll notice in the upper left-hand corner, there are 3 very large facilities. Those facilities are consuming the majority of our eHealth or telehealth programs at this time. Partly because they're St. Luke's operated. We have a very clean operation. We operate on the Epic platform so that information transfers back and forth freely. And then being able to understand the benefit of these local or smaller hospital markets and the benefit eHealth brings to them has been a fun project. As you go around the circle counterclockwise, you look at that the facilities are smaller in nature just because they use fewer or less programs, all the way around to our patient home program, where we have, in conjunction with our home health and our hospice program, a CardioCom product, and then also the non-St. Luke's facilities that we're working with at this time. In the center are services that we are offering now or have offered in the past. As most of you are acutely aware, we often live or die depending on physician availability or provider availability. So oftentimes we'll have services running, and if we lose a physician in a group, then that volume that they're able to see is reduced, and we have to modify or reduce those clinics. But we're up and active with each one of these at this time. This is our InTouch Graph, and basically as a user of the InTouch product, we have decided to go with the RP Lite. For various reasons internally it made sense for us, but as we've proliferated that product out into the area, we started first obviously at our facilities to prove the concept. As we proved that concept, one of the facilities you'll hear more about in just a moment from Dr. Ripple is Hedrick Medical Center. It's kind of an interesting anecdotal story, but when we started at Hedrick, we had to do a lot of the ROI work and the performer work, and as we did, we began to show that, hey, if the number of patients that you need to keep based on the amount of revenue per inpatient discharge. Okay, that equation looked good, but they finally converted and they purchased their first InTouch RP Lite. Within about 45 days, I received a phone call from the current CEO or the then CEO at Hedrick, and he said, hey, we need to order a second RP Lite. And the reason was that he realized how busy that unit was becoming already in the outpatient world, and he wanted one available for his inpatient market as well. So as we've proved the concept, we've been able to validate that it's the right model for us. And as we've done that, we've been able to keep patients in community hospitals that normally would have been transferred out. And obviously that's where we want to be in our relationship regionally, but also because oftentimes we, like many of you probably are in your tertiary facilities, have to go on diversion. And we don't need patients coming into our facilities here in the metro area that don't really justify being at that high acuity or that tertiary quaternary level. Many challenges occur amidst change, and then as change happens more rapidly, the challenges come more rapidly. And oftentimes we don't have the capacity as human beings to understand all the medical knowledge that flows at us at the pace that it's coming right now. So as we go forward in that continuum of time here on the lower axis moving to the right, we have to be able to identify ways to mitigate this knowledge gap. And we found that telemedicine and eHealth is a perfect way to mitigate that gap. Our key initiatives, I'll run through this and then I'm going to hand it over to Dr. Ripple, but our key initiatives with St. Luke's and our eHealth is to integrate technology to provide patient services that will obviously enhance patient access to specialty care. We've talked about that. To enable rural hospitals to retain appropriate patients and earnings. And if you think about that for a moment, it makes sense for facilities, families, critical access hospitals to desire to keep those appropriate patients. But what we're really saying is we want to keep those appropriate earnings too, because you work hard to get that patient into your facility, to work closely with the providers and the caregivers in your community, and that way you would be able to retain those earnings in that local community and setting for all the ancillary services that would be provided for that patient beyond just that initial eval. We want to improve efficiency and save dollars within the St. Luke's health system and regional hospitals, to project the St. Luke's care best practices to improve patient health, also increase those St. Luke's referrals and name recognition, obviously being able to market our services out, and we're very proud of the reputation St. Luke's has in this region. improve our local physician efficiency and job satisfaction. That's one right there that oftentimes people don't recognize. When you start a telemedicine program, you think, well, it's just one more thing to do. But in all actuality, if you can get beyond that initial reaction, you can improve the job satisfaction, because some of our physicians, I'll use our nephrologists for example, when they started, they were traveling to several locations or had a very limited outreach impact or footprint. Now they're traveling by video or virtually to multiple communities, spreading the breadth and the sphere of their influence, but they're never leaving the plaza here at the Plaza campus to do that. We're also increasing St. Luke's outpatient, inpatient volumes. We want to maximize that doctor efficiency by placing convenient, easy-to-use, standardized telemedicine nodes in appropriate clinics. And what that allows us to do, it allows us to shift from being reactive in our market to just-in-time care and preventive care. And we believe that that is all a part of the sweet spot that we're able to establish here within St. Luke's.
As Steve said earlier, this is Gary Ripple. As Steve said earlier, the main impetus for the St. Luke's system of eHealth is we want to partner with the patients and their providers to keep them in a hometown setting. And what you find is that I grew up in a small town, Hiawatha, Kansas, and about 4,000 folks. I hadn't grown a lick since I left several years ago. And what we know is that providers, after they leave medical school, don't see the high acuity medicine, and so they feel uncomfortable about the way they practice medicine. And so when someone comes in with something a little about a patient out of the a little higher acuity, they usually get transferred. And you see this over and over again, because it's not that the providers don't want to provide care, but they want the best care for their patients, and so they will transfer the patient. And so when we set out, our eHealth is we had several things that we wanted to do. Was to improve that the regional health within a 150-mile area. We wanted to integrate it into what we currently did in the boots on the ground and all the clinic services. So rather than create a whole new separate eHealth, we wanted to embed eHealth into our current system. We wanted to be affordable, because there's not a whole lot of money out there, and so our regional hospitals needed to have something, a partnership with us that they could afford, and so we had to make the eHealth provisions affordable to them. And then we had to convince the St. Luke's providers that the importance of this, and that really it's all about touching more patients. As we get into the management mode of care, there's not the way to make the same amount of dollars is to touch more patients. And so we know that 20% of patient population that is out in the region, we need those to be coming to St. Luke's. And so we want to partner with folks, and we want to be the provider of choice in this region. And then on the flip side of that, getting the regional physicians to use us, the local physicians, sometimes they have the big brother approach, that they feel that they don't want anybody else in their business. And so we had to prove to them that our purpose was to improve patient care, not to steal patients, which is what they were sometimes thinking. And then the patients had to become comfortable with the technology, and they needed to be able to accept a video specialist, a consulting specialist, rather than coming to the city. And once when the patients found out that they could get the same provider that they would see if they came to the city, and they were able to get that virtually without having to travel and the expense and the time, etc. It was interesting how rapidly the patients accepted virtual care. So and along with all of this, the IT issues really aren't a problem. They're the virtual medicine capabilities, the technology is there. You can, whatever you need to do, you'll find something to support that, an IT support. We have chosen InTouch. We're very satisfied with InTouch because it provides the flexibility and the high-end use where we can do a full physical exam rather than just a video connection. So we had a triple aim. One was to improve the health, and that really was what drove us. We are all about improving patient care. If you know anything about the St. Luke's health system, we have tried to standardize and protocolize the way we do business. We have a very interesting, 4 or 5 years ago, they started a thing called St. Luke's Care, and that is a protocol algorithm-based system of care that all our providers use, and that really forms the basis for how we do care throughout the region. Everybody gets the same level of care, and it's all about transferring knowledge. So we were all about improving healthcare by transferring the specialist knowledge to wherever it was necessary. And then partnering with the local physicians. We firmly believe that local physicians and the support structure of their community gives the best care available. And so part of healing and curing is having the patient remain in a place where they have the love and assurance and the support that they need. Sometimes bringing them to the city is counterproductive because it disrupts that. And so we want to provide as much care as we can in the local community. And along with that, we had to figure out a way that we weren't going to do this at an added expense. We needed to figure out ways to pay for the program that was paid for either by the reimbursement or by an improvement in the quality or the decrease in transfer or keeping patients in beds, et cetera. There are a number of reasons to do eHealth, and it kind of changes for the situation. So we're going to look at Hedrick. Hedrick Hospital. We're going to show you this as an example. Now remember that every small hospital is different, but Hedrick Hospital is in Chillicothe, Missouri, which is a small critical access hospital. And over the years, just like I said before, the providers, very hardworking providers, and we've worked with them a lot, but they really had they were struggling because they weren't comfortable, and they were having to pass our cardiology and stroke and other patients to the city, and so they were really becoming a pass-through. The CEO jokingly put a sign or put a slide together that showed an ambulance with a taxi sign on it, and that's kind of how things were there. It was just a pass-through. Patients were coming into the emergency room and coming immediately to St. Luke's for a higher level of care. And from watching, they had the EICU, and from watching them from a distance, it was I could see that if we could just put some specialty care in their inpatient services, some virtual inpatient services, that they'd be able to keep a lot more patients. But you can see between 2011 and 2012, that red line, their admissions were going down, their transfers were going up, and about 2013, they were really in desperate straits because they were in the red. So we looked at several things, placing physicians there, the subspecialists, totally out of the question because there's not enough volume there to keep a pulmonary or cardiologist busy. Using nurse practitioners and on-site e-hospitalists with e-hospitals, what didn't seem to be the right mix. And so the hybrid model was to provide specialty care and then add into that local Monday through Friday hospital care and supplement everything with the e-hospitalists and the virtual medicine. So what happened, we started that in late 2012, and you can see that the admissions shot upwards in 2014, and the transfers went down so much so that their 25 beds are pretty much full all the time. We have a pulmonary, cardiology, nephrology, inpatient, and infectious disease inpatient e-consults that is available Monday through Friday, 8 till 5. We don't try to do the weekends or overnight. We figure if they're that sick, they should come and transfer anyway. So we just do it during the week, and but that alone has been able to keep patients there. And I'll tell you that the doctors at Chillicothe were a little suspicious, and they were saying, "Oh, we don't need this. We're not sure we're going to use that." Well, it wasn't 2 weeks. I was getting calls from them saying, "Hey, can we extend this to 24 hours and on the weekends?" And so it was a success right off the bat. The physicians locally bought into it. The patients loved it because they didn't have to come to the city. We figured that the first 40 patients that we treated probably saved the patients in total about $40,000 in lost wages and transportation and rooming costs if they were to have come to the city. And so it's been a tremendous benefit for the patients, the providers, and our providers here at St. Luke's, the specialists that give in care, have really gotten on the bandwagon, and they have really accepted this, and they see the need for this. And it's been able to keep patients that don't need to come to the city in their local support system. It's provided financial support for the hospital. The patients are on board with it. Our CEO likes to tell the story of a 78-year-old gentleman who came up to her when they opened the new facility at Hedrick, and was just saying how much he appreciated the eHealth program, because his wife, who had a cardiac event, was able to stay put in Chillicothe, and he didn't have to make the trip to the city to be with her. And she was treated very well. One of the things that is important is that we are staying within the 150-mile radius, primarily because we believe that the patients should be able to see the same provider that they would see virtually. And it's a big confidence builder for the patients, realizing that, yes, I'm seeing the provider on the video, but I could go and see them in person if I need to. And sometimes that does happen. So we like to look at this and call this our smiley face slide, because you can see that the admissions have created an upturn, and they continue to climb. And so these are just some of the cost benefits that you'll see. We initially started with just pulmonary and cardiology services. We advanced to infectious disease and nephrology, added on the ground hospitalist services during the week with mid-level support during the weekends, and that's supported night and day by a virtual e-hospitalist, again using the protocol medicine that we would use here at the plaza, the flagship. So this is all integrated and is system-wide. But this was the most recent cost analysis. The revenue was over $1 million. The direct costs were only about $200,000, with a net income of about $1 million. So they're now $1 million in the red, where they were, in the black, where before they're about $1 million in the red. So cost effective, absolutely.
We're going to try and experiment just a little bit with technology. We're going to click on this and hopefully show you a video that we did specifically about Hedrick Medical Center. So we'll give it a shot.
The benefits of eHealth services at Hedrick Medical Center have been many. First, and ultimately the patient. What I mean by that specifically is they're able to stay in their home community and receive services that they wouldn't otherwise be able to receive without eHealth services.
Benefit for me was I did not have to go to the city. I could stay here and be with the people that I know and feel comfortable with.
I can't remember anything that has not been covered through telehealth, due to my health. I've been all over, starting from diabetes, and then stroke, and bleeding, something like that. And I also had a wound. We have services that we would not otherwise be able to deliver in a rural setting like Chillicothe, Missouri. And so what we have is an opportunity now. We've seized that to become a regional medical center.
It's the same as going to the doctor's office, and because you have a nurse that comes in and takes all your vitals, and I think she's already told Dr. Jen before she, before she starts talking to me that, what the progress is for today, or the results of the blood pressure and everything.
They're already comfortable with you, so that really helps to ease the patient's fears.
When you're around other people that you're more at ease.
the patients are very thankful that they are able to receive a higher level of care right here in their hometown, not have to travel.
And so this was really neat that I could see her, I could come here to my hometown and solve the problem here instead of having to go to the city.
So what eHealth services have allowed us is to start a hospitalist program that we would have otherwise not been able to do so. And this has really helped with recruitment. We've been able to get a few family practice physicians that if we didn't have this service, point blank, they wouldn't come. And I saw Dr. Lenny, a person, you know, who brought me hope. And that was a connection. I felt very, very careful holistically. It's great benefits to the community as a whole, including our hospital in times of increased pressure on reimbursement. We're able to keep more patients here at Hedrick Medical Center, which in effect lowers the overall cost of the healthcare system, the patients, puts less burden on our ambulance, and also satisfies patients because, again, they're able to stay right here in their home community. To people who are maybe worried, maybe nervous like me, I used to be, I would say, you know, please go ahead. This is a wonderful thing to do because you will be able to be seen by the expert, and technology will follow you where you are and meet your needs.
So that's our eHealth video. We have
Hey guys, my presentation is on telemedicine. And telemedicine is a concept that's driving change.
There we go.
So can you hear me? I hope you can. That's the video that we have that allows us to maybe just share a little bit about where we've gone with telemedicine from a single site perspective. But as we move forward, we think that we can replicate that both within our system and with non-St. Luke's facilities. And again, there's a certain competitive part of all of our facilities and how we participate and compete. But then there's the part of patient care, where we think that there are certain things that seem to be just emerging that are right for patients. And as you can tell by the two testimonials that we had on the video, we could have had probably 100 other folks that have had a similar experience, but they were very appreciative of the opportunity that, as the elderly lady said, to stay at home. They didn't have to travel to the city to get that care. And that's where we think that greatest opportunity is. Where do we go from here? Our ability to continue to grow our eHealth program looks at several different opportunities, a few that we really think are going to emerge over the next 4 to 5 years. And that fact that we this year will exceed 10,000 eHealth encounters, that we'll have a process standardized across all service lines, in which, as Dr. Ripple talked about, the St. Luke's care protocols, that whether you live in a town of 5,000 or whether you live in the middle of Kansas City, the same protocols of care can be delivered regardless of that geographic location. Another opportunity, and we haven't talked a lot about that, are innovative revenue streams. For us to be able to move forward, we need to be able to think of new and innovative ways that we can help generate revenue within the system. And that can come from what some would consider non-traditional care in the sense of managing or offering second opinion services for folks virtually that allow them to interact with St. Luke's through telemedicine that never would have before. Another emerging technology is eHealth. I know that, again, if you're motivated enough to be on this webinar, you're well abreast of what's going on with eHealth and the proliferation of handheld medicine. Whether that's wearing a Fitbit on your arm or whether you're looking at providing a telemedicine consult on your cell phone or smartphone, all of those pieces of eHealth are going to continue to expand and grow, both from a legislative standpoint, reimbursement standpoint, and a provider standpoint. We can resist that expansion, or we can look at that as an opportunity and a chance to participate in that change within healthcare. Another piece is expanded inpatient consults. That's one area that because of the growing population that's over 65 and the shrinking number of specialists, we've got to figure out better and more efficient ways to manage those patients inpatient-wise, even in our metropolitan areas, through telemedicine and transferring that knowledge virtually. Post-acute monitoring, most of you are familiar with remote patient monitoring. It is through a home health program. That is one area that is going to come in much more into vogue across the nation, simply because we need to be able to support and encourage patients to make good health choices once they've been in our facilities. Obviously, to avoid bounce backs, 30-day readmissions, which will soon be 60 and 90-day readmissions, we need to be able to look at technology and how that helps alleviate some of those issues where patients either have missed appropriate medications or they've made poor choices. With that constant reminder and that reinforcement, we feel that we can make a difference, and it's showing that in some of the studies across the nation. And the last one is chronic ambulatory care. It may be those folks that are diabetic, or maybe those with COPD, that they are chronically ill, but you can help manage those patients through technology, wherein historically they may not have had the support group nor the reinforcement to make those good choices about their health care. We appreciate the opportunity to share a little bit about what St. Luke's is doing with eHealth. I believe that Andre and the team from InTouch are going to take back over the controls at this point.
Steve and Dr. Ripple, thank you so much for that wonderful presentation. So now we're going to begin the question and answer portion of the webinar. So for the audience, please make sure you get your questions in through the questions module located on your GoToWebinar panel. The first question that we have here is from Olivier, and he asks, as you expanded your clinical services, what was your process or method for determining which applications came next? Were you actively reaching out to departments, or were they coming to you? So was it more of a bottom-up or a top-down approach?
This is Dr. Ripple. Olivia, that's a great question, and it's really an integrating question, because we have our eHealth directly linked to our outreach program. And so as the outreach folks were talking with the needs of the region, they would identify specific clinical needs, and they would bring them back to the eHealth department. We would go to the providers of choice, and we would find within the system providers of that specialty with a capacity to add into their services. And one of the things that I didn't mention earlier was that we don't use the plaza physicians much at all. We use our specialists that are at our St. Luke's North facility because they had more capacity. So that's a great question, because it really is probably more of a bottom-up approach, knowing what the need is and then looking for the capacity to supply that need.
Fantastic, thanks. So we have another question from Chris. What are the challenges that you see ahead in the transition towards developing eHealth business models into ACO/community care environments?
I think one of the obvious challenges in converting that is to understanding what the needs are in the community. I think the ability to migrate to an accountable care organization is really understanding, where those chronic issues are within that particular geographic population, and then also matching those services within your provider groups. Physicians have to transition their whole way of thinking if they're going to provide or manage those patients in an ACO, where in the past we've been simply managing that chronic experience once they hit our office. We've got to convert that way of thinking to managing those patients prior to hitting that office and keeping them healthy.
And the challenge is that it's all a reimbursement. And as Steve said earlier, eHealth varies from region to region in the country, because if you're on either coast, you're more focused on ACOs and managed care, whereas if you're where we are, we're really a fee-for-service, and so the reimbursement models are entirely different for those. And so what we're looking at is unique ways of providing partnering with wherever the funding source is, that will allow us to improve to set the clinical services that are available. We have not yet gone much into the chronic ambulatory care mode. We're ready to do it, but there's no way to fund it right now. We do have a little bit of our post-acute care monitoring at home, but again, it's funding limited because there's not a whole lot of money in the post-acute care and chronic care reimbursement, not enough to support the infrastructure that we know that we need. So right now we're focusing on getting our foundation for the higher level of acuity, realizing that eventually we're going to be pushing the virtual medicine into the more of the chronic care, and usually using not providers necessarily, but care coordinators and care coaches that will provide care. But again, that's in the future for us.
Great, thank you. We have a couple of technical or operational questions coming in, and just as a note to the audience, if we don't get to your questions in time, we will have contact information on the next slide for you to be able to reach out directly. So one of the questions here was, when introducing new platforms such as the RP Lite to the hospital that could benefit from these services, what types of training or onboarding steps did you take? This was from Joel.
Joel, you know, nothing's done till the paperwork's done, and being able to really focus on that onboarding piece has helped St. Luke's. One of the ways that we first introduced it is that we worked with InTouch to do a pilot. And the pilot basically was a unit that we had at Hedrick Medical Center, and we had the physicians here at the main campus in the physician lounge and also the physician dining room. For 12 hours, we introduced all of the specialists who might have an interest in doing this. As they came into the lounge, as they came into the dining room, we had them connecting right there, real time, with the folks in another facility about 180 miles away. And so that's one of the ways that we introduced that. The technology itself and being able to get doctors on board, it's very intuitive. And in a matter of 15 minutes, we introduced it to one of our cardiologists, and in a matter of 15 minutes, he was able to connect, navigate, be able to get to, and he said, I can make this happen. He said, I've seen enough. So really, if you outline the target and the populations you want to take care of, the technology is very intuitive.
Well, one thing I'll add to that is that the technology is only part of it, and process. It's all about duplicating the process. And so when we started this at Hedrick, we developed a procedure of just a timeline, a check sheet of what all needed to be done prior to, during, and after the virtual visit. So it doesn't just happen. What I would recommend is that you standardize as much as possible the process of doing telemedicine so that you can replicate it in whatever services you did. That's been highly successful for us.
Great, thank you. We have a question here from Roger. You mentioned in the presentation about your physicians. Many of the physicians are located at other facilities. The question here is around, do you see a physician capacity where you will reach your own internal limits of the health system and have to look outside your own health system to gain additional physicians to support your program, whether they're virtually, outside the state, etc.?
We're already there. That is the challenge of every healthcare community, I think, and that was, if you were at the Innovations Conference that InTouch put on in Santa Barbara, that was the theme, and it is absolutely correct. There is no way that any health system can have enough internal physicians to provide the capacity of care that they need. Now we're doing pretty well, but we are bumping against that capacity. So yes, partnerships are becoming part of what we do.
Great. And so we have another question here from Laura. Laura asks, you mentioned the EHR integration being helpful for your St. Luke's partners. Does that integration assist with documentation of the consult for both your St. Luke's and non-St. Luke's locations?
Well, and that is an issue because we have Epic for internally, but we're also managing in the EICU. We do Meditech, health systems, etc. And what we have done is we have said Epic is our system. That is what we're going to do our work on. And if anyone else wants to use our system, then we will figure out a way of transferring the information. One of our main goals, and one of the reasons that we got our specialists to go on board with this, they didn't want to learn 5 different electronic medical records. What we did was said, okay, you use the medical record that is in your clinic that you feel most comfortable with, because that's where you're going to be able to document best and to provide the best information for reimbursement. And then we will either digitally transfer that information to the electronic medical record, or most commonly what we do is print it out and fax it to the outside provider where there's a desperate EHR, and then it's scanned into that electronic medical record. Now, it varies place to place. That's just kind of in general how we do business. But in order to get our providers to accept telemedicine, we had to make the provision that they would not be learning a lot of new electronic medical records. And so we use what they have in their clinic, and then we fax that information or digitally transfer that information to the outlying hospitals.
Fantastic. All right, so Steve and Dr. Ripple, I'm going to turn it over to Larissa for some closing remarks. Thank you guys both very much for your comprehensive and excellent presentation.
Thank you, Andre. Okay, and we would love to just say thank you so much to Steve Kropp, Dr. Ripple, and St. Luke's for today's presentation. Please remember that for any additional questions or information, you can always contact us at questions@intouchhealth.com, or you may contact Steve or Dr. Ripple directly at the email addresses shown on the screen. And then also remember to visit our website to find a recording of this webinar and a list of all upcoming webinars in our series. Do you have anything else to say, Steve or Dr. Ripple?
No, thank you for the opportunity.
We just appreciate the opportunity. It's all about getting the care to the patients.
Thank you so much.
All right, with that, we'll be ending the webinar. Thank you.